All right, so today we're going to talk about the respiratory system. This, together with the cardiovascular system, is what brings a lot of people into the hospital, or it's a chronic condition that people struggle with that puts them at risk for death, especially when we're talking about influenza or the coronavirus. People with emphysema, asthma, bronchitis, they're at big risk for not being able to tolerate even the common cold. Even the common cold that goes around that's not influenza, it turns into pneumonia for people that have poor respiratory function. And then we talk about, kids that are born with certain genetic disorders or trauma that happened during pregnancy or childbirth, where they end up with cerebral palsy. They lack the ability to clear their airways, clearing their secretions, controlling their secretions, so they can't cough. If you get a little cold and you feel that junk collecting in your airways, you cough it out, right? And then it goes away and you can breathe better. But people with neurological diseases like cerebral palsy in kids and all the way into adulthood, that's usually what they die from, is chronic infections that they just can't clear. And then people with multiple sclerosis have a hard time clearing their airways. And then also people with Lou Gehrig's disease, that's a real problem. And then other kids that are born with, and Lou Gehrig's disease is an adult disease, but kids that are just born with chromosomal abnormalities, and they're very, very developmentally delayed, so they can't cough like they need to clear their airways. So these diseases that go around that we take for granted, and one of the most frustrating things I hear from parents and just the general population is, I don't get my flu shot, because if I get the flu, it's no big deal, I'll get over it and I'll be fine. I'd rather get it the natural way. Well, the unfortunate part about that is the person, that they are leaving their germs around, that comes in contact with their germs on the grocery cart or on a door handle, those people can die from influenza. So it's kind of a selfish attitude to say you're not going to vaccinate yourself or your kids, and you're going to keep this virus going so other people get it and may die from it. So as healthcare professionals, it's really our responsibility to keep ourselves as healthy as possible. And we do know that immunizations work. Some people get a little sick from it. That is true. Some people say, I had diarrhea and fever for 2 days. But that's nothing compared to influenza. So you just have to really educate people on the benefits of immunizations. And we've literally eradicated polio here in the US with a strong immunization effort. So we know that immunizations work. And the influenza virus is not perfect because we don't have good inoculation rates where people are getting vaccinated. So it tosses around person to person and mutates and mutates and mutates. So we always need to get a new vaccine every year to get the most recent mutated influenza virus. And sometimes we even miss it, right? Some people have had their flu shot and still get the flu. But it's still better than no influenza shot. We find that more people's lives are saved that have gotten the flu shot than haven't. So it's really important that we educate. And you guys are a group of people that can bring that information and spread it out to your coworkers. Because I have people that I know that are in healthcare that still refuse to get the flu shot. And it's just bad information. And in my biology class, we talk about it in great detail. And I have charts showing deaths due to measles, mumps, and rubella before the vaccine compared to deaths after. And there's no contest. But people don't research it in depth, so they don't understand it. And they just listen to hearsay, and they don't vaccinate. So it's really, really important we vaccinate to help these people. And do you remember from lab, what kind of diseases are those where you can't clear your airways because of some problem with inhalation, exhalation? Obstructive diseases or restrictive diseases? Which is it? What do you think? Obstructive means there's something that's blocking the airway. Restrictive means something is restricting the ability to clear, to inhale and exhale forcefully. And old people with a stiff rib cage and weak muscles, because they're old and frail, they can't cough and clear their airways either, so they're the ones that are also at risk of dying from influenza or the coronavirus. And also they have a weakened immune system as we age. That's another reason that people die from influenza and coronavirus. And I've been fighting this cold for like 3 weeks now. And one thing I know I haven't done, which I need to do, is exercise. They really strongly, and you're going to learn this with your study of the immune and lymphatic system, is these viruses and bacteria live in our lymph nodes and our lymphatic ducts. And when we exercise, that promotes lymph movement and pushes things through the lymph nodes and clears the blood and expands the lungs and helps get that junk out of there. So if you've been fighting a cold for a while and just feeling kind of tired and icky and blah, make exercise a part of your routine. I mean, not serious exercise where you're exhausted, but get your heart rate up, get a little sweat going, and you might find you're going to kick that virus faster. Because we find people who exercise don't get ill as often as people that are sedentary because of that lymph activity. Okay, so respiration has a couple of terms related to it that we're going to talk about. So the first one is ventilation. We talked about that in lab. That's just the moving of air in and out of the lungs. So if a person is on a ventilator, that means they cannot move air in and out of their lungs. Something is damaged with the respiratory system or the nervous system that it's not feeding the body like it needs to. Or some people have such damage to the lungs that they need extra help with ventilation by supplying extra oxygen, changing the pressures involved with inhalation, exhalation for the patient because their lungs are so damaged. So ventilation is just the movement of air in and out. And then we have external respiration, which we're providing oxygen from the lungs to the blood. So that oxygen came from the outside air and then it's moving to the blood, so we call that external. And then the circulatory system, which is the heart and blood vessels, right? The cardiovascular system, that transports that oxygen in the blood to the tissues, and then we're feeding the tissues with oxygen. So that is called internal respiration. So oxygen provision to the tissues. And at the same time, carbon dioxide is being picked up and delivered back to the blood to be exhaled out from the lungs back to the outside air. So it all starts with the atmosphere, moving into the body, through the lungs, and then into the blood, and then into the tissues. That's the ultimate destination of oxygen for humans. So recall some anatomy. We have these airways. We have the trachea that leads to the bronchi, primary, secondary, tertiary. Then it branches 21 to 23 more times before we hit the bronchiole. And the bronchiole has smooth muscle. And we see these embedded in the lung tissue, right? We looked at slides of that in lab, and you could see the darker edge of the bronchiole versus the alveolar duct. An alveolar duct is just a passageway. It's simple squamous epithelium leading to the alveolar sac, which leads to the alveoli. So alveolar duct is the hallway. The sac is a cluster of alveoli, and then each individual sac is the alveolus. And they are surrounded by capillaries for good gas exchange. So I think of kind of like when you throw soccer balls into a netted bag. The net is like the capillaries, and the soccer balls are like the alveoli. So there's that exchange. As soon as that oxygen diffuses across the wall of that simple squamous epithelium, there's a blood vessel there that's also simple squamous epithelium, which is very thin, and then it reaches the bloodstream and it's whisked away to be used by the body. So it's good to have this thin membrane of the alveolus and the blood vessels, so we have rapid exchange, dumping off of CO2 into the alveoli and the diffusion of oxygen out of the alveoli to the blood. And it's all diffusion because carbon dioxide and oxygen do not need a carrier across the membrane. They just simply diffuse across according to their concentration gradients. And we're always going to have higher oxygen in the alveoli because it's coming from the outside air where it's ultimately the highest concentration. So once it enters the body, it's always going to diffuse out of the lungs into the blood. And the tissues are always the lowest part of oxygen because we're constantly using oxygen for metabolism, right? Breaking down glucose to make ATP. And carbon dioxide is always highest in the tissues because we're constantly making it there and then diffusing it out to the blood and then to the lungs and to the outside air. So the respiratory membrane is the blood vessel, the pulmonary capillary, and the alveolus that are in direct contact and have just a basement membrane between them. So there's quick delivery of oxygen and carbon dioxide in either direction. So it's the alveolus and the pulmonary capillary walls. And again, it's simple squamous epithelium, and they're made of type 1 alveolar cells. The type 2 alveolar cells are scattered among them, and their job is to secrete surfactant and antimicrobial proteins. So we have type 1 and type 2. I'll change the type 2 surfactant. So these are cuboidal cells. They have a little more of a job, and that is to protect these airways, keeping them open. So here's a nice example. Remember I said the soccer balls in the netted bag? So there's the pulmonary capillary, got the alveoli, and that's the respiratory membrane. Then we have these bronchioles bringing the air into the alveoli. So again, this is the respiratory membrane. And it should be very thin if a person has healthy lungs. So this is, again, I don't know if it'll let me highlight or not. This is the respiratory membrane. So again, this is the lung. The alveolus of the lung. And this is the blood vessel, the pulmonary capillary, right? So we're always going to see oxygen going from lungs to blood. We're always going to see carbon dioxide going from the blood to the lungs because that's the concentration gradient. That's where they're higher in concentration. So if you look at a cross-section of an alveolus, which is shown here, you can see those simple squamous epithelial cells, which make up kind of the brick and mortar of the alveolus. And then we have some macrophages, which are immune cells that are protecting the lungs from infection because the air we breathe is not sterile, right? There's a lot of junk in the air. And hopefully the mucus catches a lot of that as you're bringing it into your airways. But if it does make it to the lungs, we have these macrophages that are present. And then we have these green cells, which are cuboidal cells, and they are those type 2 surfactant and antimicrobial protein producing cells. They're just kind of scattered about. Now, if you have COPD and you expose these alveoli, which are very delicate, right? One layer of flattened cells, chronic exposure to cigarette smoke causes these walls to break down. And if you break the walls down of these alveolar sacs and you have less soccer balls in your net, then there's nowhere for this air that we breathe in, that we bring into the bronchioles. There's nowhere for that air to go because these alveoli are blown out and missing, broken down. So air comes in and it gets just trapped in these open dead spaces of the lungs. It's like taking a sponge and pulling a big chunk of the sponge out, and you try to soak up water. Is there less, wouldn't it be harder to soak up water if I had a sponge that had big chunks taken out of it, right? So it's the same thing as our alveoli. If we break down the sacs of the alveoli, there's no surface area for gas exchange to occur. So people get trapped air in their lungs because the alveoli can't contract and push the air out, so it just gets stuck in there. So people with emphysema make the sound because they have to push their chest in to force this trapped air out. And I had a classic example of that. We were picking up a kitchen table years ago when my kids were little and we moved into a big house. And I wanted to get a big table because I had 4 kids at the time and they were all little. And it was a Formica top. And I don't know if you know Formica tables. They are really, really heavy compared to a wood table. We didn't know that, so we went to pick up this table, and this old couple got this table used in the 80s, and it was in great shape still. So and then my daughter's going to use it now when she gets her house, so this table is awesome. But it kind of has this kind of a top, and kids can't damage it. That's why I wanted to get it. Anyway, they're helping us move this, and this guy is about to collapse. I mean, just bringing a chair from the dining room to the front door where we were loading it into a trailer, he was going, and I'm like, please sit down. We'll do this. I don't want him to die while we were picking up this table. But it was, I mean, barrel-shaped chest. Because of that trapped air, people get this really big chest. Classic example of emphysema. And when does this breakdown of the alveoli happen? We have so many alveoli in each of our lungs, it's a gradual process. It happens in the 20s and the 30s and the 40s and the 50s and the 60s, 70s, and then by the time you get to be 60, 70, 80, so many have been blown that now they feel the effects of it and they're miserable. Can we grow alveoli back in a dead space? No, these cells are not highly mitotic. They don't replace themselves. So once they're gone, they're gone. Kind of like our brain cells, right? We laugh and think it's funny to drink to excess, like on the weekends, and oh, he's just a partier. He likes to have a good time. Talk to those people when they get to be 70 and 80. There's a lot of alcohol-related dementia out there for people that have been heavy drinkers their whole lives. Their brain cells, again, damaging more and more brain cells, they are not functioning well in those older ages. So we need to respect and take care of our alveoli. And if people have another chronic obstructive pulmonary disease, it's not just emphysema. COPD is what that stands for. It's also asthma, because if I have a reactive airway and any little disturbance in the air or exercise causes my smooth muscle to constrict in my bronchioles, people get severe asthma. And bronchitis is inflammation of the airways, and people can have that too. And the people that are really at risk of that are kids that are born premature, because they need special supplemental oxygen when they're getting started and their lungs aren't quite developed when they're born, and they have to really work hard before they're ready. There's some damage that occurs during those early months, and they have chronic respiratory infections. And again, when I worked on pediatrics on call for a while, we had a lot of young kids come in that were preemies at birth, and anytime they caught a cold, bam, their oxygen levels went down, they became really asthmatic, and they needed to come in and get steroid injections, breathing treatments, and to be on oxygen for a couple days. And my big job was giving Tylenol and changing diapers. So for me, being on call, I couldn't do like the chemo and the more advanced pediatric stuff. I just did the real basic. It was a little low-level nursing for me because kids are healthy. And all they needed was Tylenol from the nurse and making sure the oxygen was on. So, and the parents like to do everything because it's their baby, their child, right? So it was a really hands-off nursing for me. It wasn't my thing. But if you want to go into pediatric nursing, you would do more of the hands-on, more of the chemo and things like that. But kids are healthy. So pediatric nursing is a lot more hands-off than acute care, adult med-surg nursing. That's very hands-on, sometimes a little too hands-on, right? Riley, you can relate to that? So you're on neuro, right? Yeah, I worked at the jail last night. We sent someone your way. Mm-hmm. It was kind of exciting. Anyway. Well, what's nice about jail nursing, just talking about nursing, because there's a brand new nurse, just graduated, and she's working at the jail. It's her first job, is you really get to be the boss. Because someone was crashing, and they're all looking at me like, what do we do? And I felt like the doctor, because the doctor makes those calls, right? I'm like, well, let's get some vitals. I'm going to give them some nitro and call an ambulance. And I'm like, trying to think of all the training that you had, and all of a sudden you just bring it together, and it's kind of cool, And it was the appropriate thing. He was hospitalized, and he'll be fine, but it was one of those things. Anyway, and then everybody was mad at me. The med pass was late, so a lot of the inmates were like, why are you late? I said, chest pain before pills. Sorry, guys. Anyway, so back to this. The respiratory membrane, then if we look at this Phys membrane, what are some things that would thicken that? If we make that thicker, it's like swimming across the Mississippi River. If I make the Mississippi River wider, wouldn't it be harder for carbon dioxide and oxygen to get across and take longer? So what would be some things that would thicken that membrane, do you think? What? Fibrosis, yeah. And what does fibrosis mean? Yeah, thickening. When we see that, when we do chest x-rays of people with bad lungs, we see a lot of white, which is extra tissue that's picking up x-ray. And there's poor diffusion that way. So what can we do to increase that diffusion across the membrane, not fibrosis? Yeah. No. If it's scar tissue, we can't do anything about that. And that's farmer's lung. Here's another teaching point, which I had told this gentleman that came in, really bad lung, and they said it's farmer's lung, it's the beginning, he was in his early 40s. And I said, do you wear a mask when you bale hay in the fall? No, I don't have time for that. It gets hot and sweaty, I can't breathe with that thing. Well, you're inhaling all that dust and particle and stuff in the air. That is severely damaging to the lungs. The lungs are not prepared to deal with that kind of debris in the air. And it's like, yeah, you're right, I cough up black for weeks after that. Well, that is bad news. What? Yeah, right. All that debris, you know, you'd have to wear some type of protection of the airways. And farmer's lung is a big problem here in our area because we have a big farming community. We have a lot of patients from Iowa and Minnesota that work farms. And Yep. Yeah, my son is in Afghanistan right now, actually, and he said he had a cold and he was coughing up a lot of junk, and I said, make sure you go and be seen, because they need to have a record that you were having issues, so that in 20 years, when you develop some type of lung disease related to the junk that's in the air, there's a record of it. So if you have family members that are in the military, and they're talking about anything like, oh my God, I've had a lot of headaches lately, or geez, my back hurts from carrying this, you know, backpack across the mountain range or whatever, go be seen, get a record of it, because the military is great on paying people, but if there's no record, they don't know that it happened, they think you're making it up. So very, very important to record that. All right, so fibrosis, if the lung tissue is stiffened and scarred, it's going to be a bigger issue. So how do we promote, how can we give that oxygen a push through a bad membrane? Okay, we could do an inhaler to open up the airways, but if it's a fibrotic lung, what we can do is increase the pressure of the oxygen on the lung side, right? Oxygen is just diffuses across, but if we want to promote diffusion, you would increase the pressure on this side, so there's more of a push, increase the concentration of oxygen, so there's more of a push. Would you agree with that? In the hospital, we have these full face masks. They're called BiPAP machines, and it increases the pressure on either side, either inhalation or exhalation, to push air in or to get carbon dioxide out in people that have really bad lungs. So this respiratory membrane can be filled with fluid. That's pneumonia, when people have fluid on the lungs, or if they have it leaking out of the capillaries around the lungs, that is called a pleural effusion, and it's people with heart failure. They have so much blood volume and their heart can't pump it effectively to the kidneys to be urinated away. It just builds up in the bloodstream, then it leaks out around the lungs and they can't breathe. So that's another problem of a thickening membrane. Mucus that makes its way into the airways because people don't have good cilia production because of chronic smoking, that's going to thicken the respiratory membrane. Those are all things that are going to decrease oxygen diffusion, and people are going to be working really hard to breathe, right? When the body doesn't get enough oxygen and it has too much carbon dioxide in the blood, it stimulates the hypothalamus the hypothalamus stimulates the medulla to increase the rate of breathing, and people work really hard to breathe. And that's exhausting. If you walk into a patient's room and they're breathing really hard, they're burning calories and burning energy, and their body is under stress. So if we don't take care of rapid respiratory rates and help our patients breathe comfortably, they're stressing their body. And the sympathetic nervous system is dominating, and the immune system can't function properly, and they're not healing. So we need to really pay attention to respiratory rates and do what we can to get that respiratory rate down. Maybe it's anxiety. I mean, we've had patients that are, having trouble breathing, and after talking to them, I realized, you know what, this is more of a mental health thing than this is a lung thing. And then we say, do you take anything for anxiety at home? Well, as a matter of fact, I do. Well, let's get that in the medicine list and get you on that. Okay, so when we look at the blood supply to the lungs, when we look at arteries away, veins to. Arteries go away from the heart. Veins carry blood to the heart. Let's just refresh our memory on this because I'm just going to be really generic. Okay, so there's the, and I'm going to make sure this is accurate. So the right side of the heart pumps the blood to the lungs, right? So we have the pulmonary artery coming up. It branches in both directions to the lungs. Now remember, this came back from the body, right? So we had the superior and inferior vena cava coming in here, bringing their blood into the heart after it was all used up into the right side, correct? And then the right ventricle sends it to the, oh, it's going away from the heart. So what is this vessel? Pulmonary artery, pulmonary trunk, and then it branches to the pulmonary artery. Then it goes to the lungs. Don't laugh at my horrible artwork. Is it? Well, thank you. Thank you. All right, so then that blood goes to the lung, picks up oxygen, right? And then it comes back to the heart via the, yeah, I should do it over here. This is not as pretty. But what would these be called? They're going to the heart, pulmonary veins. Notice the color that I've given them. Blood is only red, it's never blue. If any of your kids come home and say their elementary school teacher told them that, please call and correct them, because that has happened before. It's just dark red if it's low in oxygen or bright red if it's high in oxygen. But it gives our skin a bluish look because of the way light reflects off of dark red blood going through the skin. So we do get a bluish hue to our lips and face and entire body if during the death process. But anyway, so this is coming back in away from the lungs back to the heart, right? So it's coming all oxygenated, ready to go. And then it goes from there to the aorta, right? Okay, so pulmonary arteries have low oxygen. Would you agree? Yes. And pulmonary veins have oxygenated blood. That's a key thing. Because they're coming to the heart from the lungs. So this is a low pressure, high volume circuit. Low pressure because think of where the heart is in the center of the chest and the lungs are right next to it. So boom, boom, there and back, no problem, right? There's not a lot of pressure. It's not coming from the arteries of the lower body with gravity. It's just right there. So it's a low pressure system, very efficient. And then around the lungs on the outside, we have these membranes, these serous membranes. So if we've got the lung, we have on the surface of the lung, so on the surface, we have the visceral pleura. It wraps around and covers the lung completely. And then attaching it to the body wall is the parietal pleura. And in between there is this space. And we call that the pleural space, or no, not the pleural space, pleural cavity. That's what you learned in general A&P, right? Pleural cavity. And that's filled with some really important fluid. Pleural fluid. But if a person has heart failure, there's too much fluid that fills up in this space. And then we have what's called a pleural effusion. And what is that going to do to my respiratory membrane? As fluid leaks out of the blood and fills this space, it's going to thicken my membrane, and people have a really hard time breathing. So what do? We try to get rid of the excess fluid in the blood vessels, and we hope that that space will be reabsorbing of that excess fluid. But if it doesn't, we go in there with a needle and we pull it out. And that's called a pleurocentesis, when we go in and pull fluid out. And some people have had 2 liters of fluid pulled out. Can you imagine that? A 2-liter bottle of soda that's all around your lungs. Think how much better they feel after that. And then we give them a medicine to make them pee a lot. So we give them what's called Lasix, which then we give them if they're really weak, we'll sometimes give them a Foley catheter, put them on a drip of this Lasix, and they make a lot of pee. And we pull the fluid out around their lungs, and they feel way better. And then they go back home, and they drink a bunch of fluid that they're not supposed to be drinking. They eat a bunch of salty food, which pulls fluid from the tissues into the bloodstream, and they're right back. And that's a big problem. It's the #1 issue across the country, is heart failure patients not being compliant with their lifestyles. They have to watch their fluid intake, and they have to watch their salt intake, and they have to take their pills, which is the Lasix, to make sure they're peeing. But who wants to be up peeing all night, right? So can you blame people for not wanting to take those pills, especially if they're incontinent and they're large and they have a hard time getting to the toilet on time? They don't want to comply. And then as a result, they end up in bad shape and in the hospital. So the benefit of this pleural cavity with this fluid for the average person is when you take a deep breath and you inhale, exhale, your lungs can slide along the chest wall with good lubrication, and it doesn't hurt. And the fluids, the 2 membranes, stick to each other because of the fluid inside there. It's kind of like if you have a sweaty glass on a summer day on a glass table. When you pick it up, doesn't it kind of stick a little bit because of the fluid? It holds those membranes together. So when the chest wall is going outward, the lung is going with it because the fluid is sticky and those membranes are attracted to each other. But what happens if I poke into that membrane? Person gets in a car accident and breaks their rib and it pokes that membrane. Or if a person has surgery and we penetrate, we're doing lung surgery, or we're working in the mediastinum on the heart, what happens to that fluid if we poke into there? Yeah, it leaks out, and then they're not sticking together anymore. And if the lungs don't stick together, or if the membranes don't stick together, the chest cavity goes out. Will the lung go with it if they're not sticking together? No. What happens is the lung collapses, and that's a big problem. So what we do for people that have had a lung collapse because of a penetration of this cavity, we give them a chest tube. And a chest tube creates negative pressure and gets this excess fluid out of there and helps those membranes become in touch with each other and work together again. So there's a couple of different terms. I think I have them listed later in your notes. I don't want to. Do I have them? Yes, question. Because bronchitis is an obstructive disease, right? Because you can't move air through. So it causes trapping of air. Because we are constantly releasing carbon dioxide into the lungs, right? It's diffused in there, so it's not in a gaseous stage yet. But when people have air coming in that they're really fighting to get in there, they have to fight to get it out too. So you get trapping of air, kind of like you see in emphysema. And the tightness of the chest is just the restricted airways. Okay, yeah. Does he feel like he has trapping of air?
Just like when he breathes, he says it's full.
Really? Yeah. Huh.
No
Yeah, no fluid. So inflamed airways. Well, think of when you've had a really bad cold. Have you ever had a really bad cold? Maybe you've gone to the ER, gone to your doctor, and they listen to your lungs, and they say, lungs are clear. And you're like, how is that possible? I am so junky in my cough and my breathing and I'm wheezing, because it's all airways. And the airways are, we have, there's sensory receptors in airways that when particles hit it, it causes them to restrict again. And that can cause pain. It can be painful to breathe when you have a reactive airway disease, which bronchitis is an example of that it reacts to stuff in the air, or if you're sick, it causes that restriction of the airways, and that's painful. And it serves as a good thing, and we're going to learn at the end of the semester what stops breathing. Do you ever breathe something in, all of a sudden you go, oh, right? And your airways just stop, and you can't breathe in because of those sensory receptors protecting the airways. So bronchitis is a painful, difficult condition. Okay, so let's talk about a couple of terms here then. And I wish I could type on here. I know there's a way, but so one is a couple of terms. One is pleural, P-E-U-R-L, pleural effusion means fluid has leaked out of the blood and is surrounding the lungs. So fluid around the lung. And it's filling that pleural cavity, and that's where they need to get that pulled out. Fluid around the lung. Lung collapse, I'm going to use a different colored, it's kind of light. A lung collapse, the emphasis is on the E. Anybody want to try to pronounce that? Very good. Atelectasis. And that stands for lung collapse. And people that are chronic smokers have trouble with lung collapse. Infection can cause lung collapse. Tall, thin, young men are in a risk factor group that they just have spontaneous lung collapse. And we've had some patients have had to come in and be on chest tubes just because their lung collapses out of nowhere. They're not sure why. Pneumothorax is when we have a positive pressure in the pleural cavity, because the pleural cavity should always have a negative pressure. There should not be any air in here. It should be only fluid. And when the chest wall is pulling away and the lungs are wanting to move inward because of the fluid in the lung, which is normal, there's a slight pull in opposite directions of the visceral pleura and the parietal pleura, which is healthy and normal, creating a negative pressure in here. When there's a positive pressure in the pleural space, that causes lung collapse. So positive pressure in the pleural cavity, and that causes lung collapse. So when we look at surgery, gunshot wounds, what else? Spontaneous, sometimes it happens just out of nowhere, called spontaneous pneumothorax. That just happens on its own. All right, so now we're going to talk about some pressures. So atmospheric pressure, what did we say is always highest out here? What gas is always highest in concentration? What? Say it louder. What gas is always highest in the air outside the body? Oxygen, yeah. So oxygen is always highest out in the air because that's where it's produced, right? The trees are producing it outside here. And then it's always lowest in the tissues. So if we give atmospheric pressure a value of 700, oh, it's right here, 760 milliliters of mercury. That's the value of atmospheric pressure at sea level. In order to get air to move, we have to create a gradient from high to low pressure. So I have a handout for you. It's in our folder. And we can talk about that. I'm going to pause this briefly. Okay, so in order for air to flow, there has to be a pressure gradient. There has to be a change in pressure, and air always flows from high pressure to low pressure. So oxygen is always highest outside, but air flows until pressures are equal. So we always have a little rest time between an inhale and an exhale. When you're sitting quietly, you breathe in, and then you breathe out, right? And there's a little bit of brief period where you're switching from inhalation to exhalation. That brief period of time is when pressures are equal between the outside air and the inside pressure of your lungs. The inside pressure of your lungs we call intrapulmonary pressure. So this is pressure inside the lungs. So when we talk about breathing, we're comparing these two. Whoa. We're comparing atmospheric pressure to intrapulmonary pressure. We're comparing those two things. So when we go to inhale, what does pressure have to be? If it's equal between breaths, so the intrapulmonary pressure is pressure in the lungs, In between breaths, it's equal, so it always eventually equals out in between breaths. What does it have to be in order for air to flow into the lungs when we exhale? Higher or lower than atmospheric pressure? Lower, yeah. In order for air to flow, the pressure has to be higher in the outside air than it is in the inside air for air to flow into the lungs. And then in order for air to flow out of the lungs, the pressure has to be higher inside the lungs than the outside, right? So how do we change the pressure in the lungs when we're exhaling and inhaling? That is the help of the muscles. So before we do that, I want to show this animation here. So if you want to click on that and watch this animation, that'll explain how these pressures change.